Hi everybody, I'm Dr. Oishika Chakrabarti. I am an SR in obstetrics and gynecology at AIMS. I have done my PG from PGI Chandigarh and my MBBS from LHMC. Today we are going to discuss some previous year's questions, the most recent previous year's questions that appeared in NEET and INI-CT vis-a-vis 2023. So let's dive straight into it. So the first question is, a 54-year-old woman was diagnosed with advanced cervical cancer. She has a 14-year-old daughter. What advice would you give to the daughter? Right. So the options that are given to us are screen for BRCA mutation, screen for PTEN mutation, advice to take HPV vaccine, and do a cervical biopsy. So at the very outset, I would like to tell you that there are two ways of solving a question. One is you know the correct option, and the second is you have to exclude the incorrect ones and then get to the correct option. So this is a classical case where you can exclude the other things very easily and get to the right answer. So first of all, we know BRCA mutation is not for cervical cancer. Cervical cancer is not a heritable cancer. So there is no point of doing any mutations, whether BRCA or PTEN. BRCA we know is for ovarian and breast mainly. And PTEN we know is for endometrial CA. So we know these two are out. Now coming to option C and D, advice to take HPV vaccine and do a cervical biopsy. So cervical biopsy we know is a method of diagnosis. So in a patient, in a woman who has come to us and on a per speculum examination, we find a mass. We do a cervical biopsy from the suspicious mass. Or if a patient has come to us for screening and on pap smear, we are getting an HSIL or some other pathology, and then we do a colposcopy guided biopsy. That is when we do a cervical biopsy. We do not randomly take biopsy from anyone. That is number one. Even if instead of cervical biopsy, they had given you an option of do screening or pap smear. We can see from the question, this is a 14-year-old unmarried nulliparous person. So we will not even go for that option. So if you look at the clues that are given in this question, we know the answer is advice to take HPV vaccine, which actually corroborates with the age group that we have defined for the people who are at risk and should take the HPV vaccine. So let's quickly revise HPV vaccine while we are at it. So HPV vaccine, we have three vaccines right now. We have a bivalent vaccine, we have a quadrivalent vaccine, and we have a nonavalent vaccine. Bivalent is protective against 2 strains of HPV, quadrivalent, as the name suggests, against 4, and nonavalent against 9. This is Cervarix, this is Gardasil, and this is Gardasil 9. So very important question that may be asked to you is, what are the strains these vaccines are protecting you against? So Cervarix is against the most pathogenic forms most commonly known to cause cervical cancer, 16 and 18. Quadrivalent against 6, 11, 16, 18. And nonavalent against 6, 11, 16, 18, 31, 33, 45, 52, and 58, right? So these are the strains that it is protecting us against. Now, who should take these vaccines? If you get a question like true or false, HPV vaccine should only be taken by females. This is a false statement. HPV vaccine is also seen to be protective for males against certain oropharyngeal and anal cancers, right? So even men can take it. The age group in which it can be taken for females and males differs. For females, the ideal age is 11 to 12 years. For males, 9 to 45 years. This is the ideal age, but this does not mean that anybody who is not of the age 11 to 12 years or has passed that age cannot take it. It can start as early as 9 years, and after discussing with your physician, it can be taken up to as late as 45 years. What is the dosing schedule? Next question, what is the dosing schedule? The dosing schedule is, if you're taking it before the age of 15 years, you need only 2 doses. After the age of 15 years, or if the patient is below 15 and immunocompromised, for example, they are retropositive, for example, then 3 doses. The doses are taken at 0 and 6 to 12 months, And in this, you take it at 0, 2, and 6 months. What is another situation in which you might need to take 3 doses even if you are less than 15 years? If the gap between the first and second dose is less than 5 months, then a third dose needs to be taken at least 4 months after your second dose. So this is it regarding the dosing. What are the contraindications? One is pregnancy. One is hypersensitivity to a previous dose, or because Gardasil specifically has a yeast component in it, those with yeast allergy. Complications may be local site reaction, but the most common complication is syncopal attack, and therefore after getting this injection, the patient should be observed for at least 15 minutes. Right, so this is it about HPV vaccine. I hope that's clear. Coming to the second question, a woman presents to you at 36 weeks of gestation with complaints of feeling lightheadedness and dizziness when she lies on her back. She says she feels all right if she lies on her side or walks. What is the most likely reason behind this? Okay, straight away we can go into the physiology of pregnancy. If a woman is lying supine, right, this is her gravid uterus. So especially after 24 weeks, the gravid uterus starts compressing your IVC. So this is my IVC. So because there is a weight on the IVC when she is lying supine, there will be decreased venous return, which will further lead to decreased cardiac output, leading to dizziness and lightheadedness. Plain and simple. Answer is B, compression of IVC. And what is the solution for this? Stand in, the patient should be told to lie in left lateral position. This is something which we commonly do when we are doing the CTG or NST of a patient, and the variability or the acceleration is not as well as we desire, and if she is lying supine, we often advise her lie in left lateral position. This will increase the blood flow to all end organs, including the placenta and fetus. Right, so moving on to the next question. A woman presents to you with 6 weeks of amenorrhea, complaining of bleeding PV and slight abdominal pain. Urine pregnancy test is slightly positive. So 6 weeks amenorrhea and slightly positive urine pregnancy test, and HCG shows 2800 international unit per liter. A mass is seen in the left adnexa measuring 3 into 2.5 centimeter, and she is hemodynamically stable. How will you manage this patient? Okay, right at the outset, what we can see is clues that they are giving you. Faint UPT, adnexal mass. These are the two things that over here are pointing to an ectopic pregnancy. Another very important hint that they have given us to solve this question is this patient is hemodynamically stable. Right, so we know if this patient is hemodynamically stable, it will never be our choice to go straight away for a laparotomy. We know we do a laparotomy in case of ectopic pregnancy when the patient is hemodynamically unstable. Important thing for students to remember is that a ruptured ectopic does not mean that you have to go for a laparotomy. If the patient has a ruptured ectopic but with stable vitals, you can do a laparoscopic salpingectomy. Right, so in this case, this patient is hemodynamically stable, so we do not need to undergo a laparotomy. So we have two options. We have to decide between medical management versus laparoscopic salpingectomy. Right, so this much is clear to us. So whenever this patient, there are certain pointers which are telling us whether we should go for this or that. Always remember, in medical management, we are giving methotrexate, and because surgery is a more radical procedure, we only want to go to surgery when it looks kind of not benign. When it is looking like a sort of benign disease can be managed medically or a smaller ectopic, that is when we can go for medical management. So we see the beta HCG over here is 2800, which is less than 5000. These are the cutoffs that you need to remember. So if it is less than 5000, we can go for medical management. If it is more than 5000, we have to go for surgical management. Then the size, if it is less than 4 centimeters, without an FCA. FCA, nothing has been given to us about FCA over here, fetal cardiac activity. If it is less than 4 centimeters without an FCA, or if the cardiac activity is present and it is less than 3.5 centimeter, then we can very well go for a medical management. And in this case, we have been giving the size of 3 into 2.5 centimeter with low beta HCG of 2800 international unit and hemodynamically stable. So the answer over here is medical management. So over here, if you look at the options, we have 3 options of medical management and 1 option of surgery. So we can rule out salpingectomy. Methotrexate is always given by IM route. So oral methotrexate can be ruled out. Now coming to options B and C, serial methotrexate with leucovorin rescue and single dose methotrexate injection. Serial methotrexate with leucovorin rescue is always given in gestational trophoblastic neoplasia and not in ectopic. In ectopic, we give a single dose of methotrexate on day 1, follow up with beta HCG on day 4 and day 7, and we look for a fall in beta HCG between day 4 and day 7. So our answer is C, single dose methotrexate injection. I hope that's clear. Coming on to the next question. A woman presents to you at 36 weeks of gestation with complaint of breathlessness and excessive abdominal distension. Fetal movements are normal, fetal parts are felt but not that well. Fetal heartbeat is heard but is muffled. Her symphysiofundal height is 41 centimeter. Her abdomen is tense but not tender. What is the most likely diagnosis? So what are the clues that are given to us over here? One is we have a woman who has 36 weeks, whose abdomen, who has 36 weeks POG. An important clue that is given to us is her SFH is 41 centimeter. We know between 24 and 36 weeks, your SFH is corresponding to your fundal height or your period of gestation if your dates are correct, right? So either her dates are wrong or there is some other problem, right? So if we quickly look at the options that are given to us, placental abruption, polyhydramnios, fetal or maternal ascites, and hydrocephalus. So what are the cases where this abdomen can look large and abnormally distended? So basically the contents of the uterus have increased. So either the baby is big or baby is more than 1. So you have a multiple pregnancy or you have a macrosomic baby, or the liquor is more, as in polyhydramnios, or you have a placental tumor like a chorioangioma, or there is something behind the placenta that is making the uterus look bigger, like a concealed abruption. Or like I said, it could just be a case of wrong dates, right? So these are the cases in which you might find that the uterus is over distended, it is bigger than it is supposed to be. This might be given to you indirectly. Instead of giving you, polyhydramnios or macrosomia, they might just say diabetes, right? So keep your eyes and ears open for these sorts of clues. So coming back to the question, so it is saying that this patient complains of breathlessness and excessive abdominal distension, and fetal movements are normal and fetal parts are felt but not that well. Fetal heartbeat is heard but it is muffled. Right. So if there is placental abruption, we know that the uterus will be tense, but it will also be tender. We do not have any tenderness in this. Plus, there is no signs of any fetal distress. The fetal heartbeat is well felt. The fetus is moving fine. So the fetus is not at distress. So it is most likely not an abruption. Coming to our second option, which is polyhydramnios. Are all these signs and symptoms being explained well by polyhydramnios? Yes. Due to the excessive distension, there might be pressure on her lungs. So she has breathlessness. She has excessive abdominal distension. And of course, the baby is normal. It is inside, it is moving well inside the liquor, the excessive liquor that is there. Fetal parts cannot be well felt because there's so much liquor in between. And fetal heart sound is muffled because of all the excessive liquor. And this will also explain your symphysiofundal height. The abdomen is also tense because of the excessive liquor that is there, but it is not tender. So our answer is polyhydramnios. Fetal ascites and maternal ascites, remember friends, fetal ascites may or may not present with hydramnios. That will depend on the cause. And maternal ascites will present with abdominal wall edema but rarely with polyhydramnios or increased liquor, right? the tension may be there, but you will be able to differentiate if you say do an ultrasound and if you are able to find an intra-abdominal fluid. Okay, so coming to the next question. 27-year pregnant woman, gravida 3 para 2 living 2, presents to you at 36 plus 6 weeks. Ultrasound is done, shows fetus in transverse lie. Liquor is adequate, placenta is normal, and she has no risk factors. Both her deliveries were vaginal deliveries. How will you manage this patient? Option A, expectant, B, external cephalic version, C, induction of labor, and D, cesarean section. Always remember, friends, whenever you have a question of transverse lie, this is the algorithm that you should follow. If a patient ever comes to you in transverse lie, is she in labor or is she not in labor? If she is in labor, there is no mechanism of delivery of transverse lie. It will lead to a uterine rupture, IUD and uterine rupture, right? So if a transverse lie comes to you in labor, straight away go for option D, cesarean section. If the patient is not in labor or she is in early labor or false labor and she has come to you, you will look at the period of gestation. So we know external cephalic version, if we do, it is stable only after 37 weeks, but it can be done after 36 weeks. So if she is beyond 36 weeks and this patient is coming to us, we may attempt external cephalic version. Right? But if she is coming to us at an earlier period of gestation and she is not in labor, for example at 32 weeks or 35 weeks, then I can just wait for her till the time that she reaches a point where I can do an external cephalic version. So I will go for option A in this case, which is expectant management. But in this case, I can see she is 36 plus 6 weeks, previous vaginal deliveries, no other contraindications for ECV. So what I can do is I can go for an external cephalic version under ultrasound guidance. And do I need to induce labor? No, I do not. Because there is no other indication for induction. Transverse lie or ECV per se by themselves are not an indication for induction. She can go into spontaneous labor because she has no other indication for induction. Right? Coming to the next question. A pregnant woman comes to the clinic. She already has twins by normal delivery. What is her obstetric formula? So friends, always remember obstetric formula to be written as TPAL, term pregnancy, preterm, abortion and live issue. G, we know it is the nth number of pregnancy. So she is becoming pregnant for the second time, so she is G2. So if I look at this TPAL, this is basically telling me term pregnancy, preterm, abortion and live. This, remember, is not the number of children. It is the number of pregnancies, right? Alternatively, instead of TPAL, you might get the obstetric formula like GPLA, in which term and preterm are combined, which is the case in this question. But mostly in INICT, you will get TPAL. So that is why I'm just touching upon this. So in this case, we know it is G2 and there has been one prior delivery, even though there are two kids. So it is G2P1. And although they have not mentioned A and live in this, you might ask, so where will it reflect that this patient has had twins by a single delivery? It will reflect in the number of live issues. So this will become G2P1L2A0. So this is how it will reflect that she has given birth through twins by a single delivery, right? Coming on to the next question. A primary gravida presents to you early in pregnancy with anemia. She is 7 weeks pregnant as seen on ultrasound. Her hemoglobin is 9%. When should iron supplements be started for her? A, 8 to 10 weeks, 10 to 12 weeks, after 14 weeks, after 20 weeks. So first of all, if we try to understand why this question at all has been given to you. This patient is anemic, obviously you need to start iron because the thing is, in an antenatal period, we know that we are starting iron in the second trimester, right? Why is that so? Is iron teratogenic in the first trimester? Why should we not give iron? The only reason we are not giving iron in the first trimester is that there is already a lot of nausea and vomiting of pregnancy, and as we know, iron is something that causes a lot of acidity and gastric intolerance, and therefore it might exacerbate this, right? So that is why whenever we are giving iron, we start in the second trimester. However, when we are talking about the prophylactic dose of iron, assuming that this patient does not have anemia. Right. In case the patient has anemia, iron supplementation should be started as soon as it is detected. Right. So she's 7 weeks pregnant and iron supplements should be started to her. She's 7 weeks. It should be started at 8 to 10 weeks. Right. Now, if somebody asks me, so this is easy enough because her hemoglobin is 9. Sometimes, there will be they might give you 7 to 8 or something like that. And they might ask you, will you give her oral or you will give her IV? You might be tempted to be like, acha, the hemoglobin is less, so let me just give her IV. First thing to remember is oral and IV take the same amount of time to act. So your rise in hemoglobin will be seen around the same amount of time. The only advantage that this is going to give you, IV is going to give you over oral, is the compliance. And the second thing to remember, which is very important, especially in the context of this question, you do not give parenteral iron in the first trimester. Parenteral iron is contraindicated in the first trimester. Second and third trimester onwards, of course, you can give iron, right? And when should you give transfusion? At any time in the pregnancy if the hemoglobin is less than 5 grams, or if there is anemia with signs of congestive heart failure, you should admit the patient and give her blood transfusion. Right. Coming to the next question. 24-year-old woman who is being treated for infertility with human menopausal gonadotropin came with complaints of sudden abdominal pain, nausea, vomiting and breathlessness. Ultrasound done shows the following. So this has already unfortunately been mentioned. What is your diagnosis? Okay, so because the answer has already been mentioned in the question, I'm very, very sorry for that. So the answer is ovarian hyperstimulation syndrome. So how do we reach this? Let's just look at the other options that we have. So the only other thing that you can actually confuse it with, you are seeing multiple follicles, right? You're seeing multiple follicles over here. So the only other thing that you can confuse it with in these options is PCO. But the thing is, remember friends, in PCO, the follicles will be small. They will be sub-centimetric. They'll be 2 to 9 mm, mostly peripherally arranged, more than 20, but they will be small follicles. These you can see, these are large follicles occupying almost the entire ovary, right? So this is an ovarian hyperstimulation syndrome. A little bit about ovarian hyperstimulation syndrome. What is the main causative factor? If I ask you, if I look down to the pathogenesis, it is VEGF, which is being released when due to increased HCG. Right? So increased HCG will cause, these ovarian hyperstimulation syndrome, which will cause release of VEGF, which will increase further your capillary permeability, and that will lead to symptoms like breathlessness, abdominal distension, because it will lead to ascites, because all your fluid will be going to your third space. There will be a lot of third space loss, right? So this is OHSS. So this diagram should be imprinted in your head. This is a very commonly asked question, and this is very commonly seen in patients who are undergoing treatment for infertility, especially IVF, right? Especially in patients who are undergoing injections of HMG. So if somebody asks you what is the order of drugs that we are giving for ovulation induction that cause OHSS, HMG causes the most, followed by clomiphene, and least to nil risk is letrozole, right? So letrozole is something that does not cause ovarian hyperstimulation syndrome. Maybe in another class we can explain why it does not cause it. Right now we are just going to do the PYQs, right? So this is the other thing. So HCG, we know the HCG is causing the ovarian hyperstimulation syndrome, which brings us to another smallish question that may be asked to you. There are two types of OHSS. One is early and one is late. The early one is within 8 days of your trigger. Late is after 8 days of your trigger. What do I mean by trigger? Once I have done ovulation induction, I want to mimic the ovulation. So I want an LH surge to happen within the body. So often in IVF treatments, after the follicles have developed, we give a trigger of HCG. So this HCG by itself, on a single follicle may not cause much, but when it is acting on multiple follicles and multiple follicles release this VEGF, this turns into OHSS, right? So early will develop within 8 days because I have given the trigger and it will develop. Late is sometimes what happens is that by itself the follicles, after they have luteinized, they are not causing that much of an increase in VEGF. But when this patient becomes pregnant And in pregnancy, we know HCG increases. This increase in HCG will cause a late sort of OHSS once she becomes pregnant, right? So, and at any time, if your patient is pregnant and she has OHSS, admit her and observe her for signs and symptoms, right? Coming on to the next question. 23-year-old woman accompanied by her mother-in-law comes to the infertility clinic. She has been having regular intercourse for 6 months but not able to conceive. What is the next step in line? So what is the definition of infertility? Regular cohabitation, unprotected sex between couple for at least 1 year, and she has only been at it for 6 months, right? So what we are going to do is we are going to reassure her and see her after 6 months. Now another variation of this question that you may get, so this is easy because she is just a 23-year-old. What you need to remember is that if she had come at say 36 years old, I would have started my evaluation and treatment for infertility. Why? Because across ages, the definition of infertility has been modified. Because obviously at 36, I have less time to fool around and do investigations than I have at 23. So at less than 35 years, we wait for 1 year. At more than 35, we wait for 6 months. And at more than 40, we wait for 3 months. Right? And what are the most important investigations that we need to get done in order to investigate for infertility? For example, if this question was say a 36-year-old has come and 6 months she's been trying, the answer would be semen analysis for husband. If the question is given to you, what is the single most important investigation for investigating infertility? It is husband semen analysis. In addition, the other things that we need to look at is the tubal status via HSG and an ultrasound. Right? Coming on to the next question. During the removal of a submucosal fibroid during hysteroscopy, a fluid deficit of 2 liters is estimated in a patient. What is the immediate complication of this? So friends, in hysteroscopy, what we are doing is that this is the uterus, right? The walls are collapsed onto each other and we want to have a look inside the uterus. We cannot look inside the uterus if the walls are collapsed into each other. So what do we do is that we push some media into it, we push a fluid into it so that it distends. It distends with this fluid, right? And then we put a scope in and we are able to see all around the uterus. So this is what we are doing. So this fluid, what it does is that some of it is going in, some of it comes out, some of it unfortunately, which leads us to be more careful in hysteroscopy, gets absorbed in the body, right? And this absorption is what causes defects, and this absorbed fluid is what we call the fluid deficit. So whatever you're putting in, somebody has to keep a check on that. In hysteroscopy, we specifically have a person who is keeping a check of how much fluid has gone in, how much fluid is coming out, and therefore what is the fluid deficit. So what is the fluid that we are putting in? So we have some fluids that have electrolytes, they are electrolyte rich, and some are electrolyte deficient. So electrolyte rich are, for example, normal saline, and most commonly what we are using for electrolyte deficient is glycine, right? So what happens in this is because the electrolyte, the problem is there are more side effects with these electrolyte deficient fluids, and that is very problematic for us. Why? Because most of the, for diagnostic, it does not really matter. If I'm just doing a diagnostic hysteroscopy, I can just use my normal saline and come out. But when I am doing an operative hysteroscopy, for example, I want to do a septal resection, or I want to, resect a myoma from within, right? So what I'm going to do is I'm going to use an energy source. And bipolar energy source is not that commonly used in hysteroscopy as of now. What we are using is monopolar energy source. So if I'm using an electrolyte rich fluid, the monopolar energy source, the electrons are sort of going to dissipate and the patient may get a shock, right? So that is why we cannot use. So most often when we are doing an operative hysteroscopy, we are using these electrolyte deficient media. So what happens in this electrolyte deficient media is, it sort of sucks in. Because it is hypoosmolar, it is sort of taking in all the electrolytes from the body, leading to hyponatremia within the body, right? which may lead to further cerebral edema. And instead of giving you this, you might have a variation of a question in which they are giving you the values of your electrolytes, or they are saying that the patient woke up dazed and confused because she has some cerebral edema. They won't say cerebral edema, but they will give you pointers like this. So in that case, you can be sure that, okay, maybe it is a complication of my hysteroscopy, the fluid that has gone in, right? So obviously the cutoff that we have for fluid deficit varies in both. So the cutoff for electrolyte rich media is 2.5 liter, and for electrolyte deficient media is 1 liter. So in our question, we have a deficit of 2 liter, and so they have not given us what kind of media it is, but they're asking what is an immediate complication of this, right? So we know there is a fluid overload sort of a situation in this patient, and we know it will lead to pulmonary edema. So the option is C, pulmonary edema. So moving on, for which of the following procedures in the given OT list can we do with hysteroscopy? The options are cervical polyp, Asherman syndrome, tubal ligation, and subserosal fibroid. Alright, so we know hysteroscopy, we discussed in the previous question. So we are putting a scope inside pervaginally, we are putting it inside the uterus. So obviously things that we need to visualize inside the abdominal cavity cannot be done by hysteroscopy alone, they need laparoscopy as well. So we can rule out tubal ligation, right? Coming to fibroid, Asherman and cervical polyp. If we talk about a fibroid, fibroids can be removed hysteroscopically, but for that they need to be predominantly within the cavity, which means it needs to be either a FIGO 0 or 1 fibroid. A subserosal fibroid, which is lying predominantly in the abdominal cavity, cannot be taken out by hysteroscopy. Not just this, any FIGO fibroid beyond 1 cannot be taken out through hysteroscopy because there is a chance that you will end up perforating the uterus, right? So we have ruled out subserosal fibroid and tubal ligation. Now coming to the remaining two options, cervical polyp and Asherman syndrome. We know Asherman syndrome is a syndrome where we have adhesions within the uterus, and we know the anatomy of a cervical polyp will look something like this. So in a hysteroscope, listen to the words, hysteroscope. So we are looking inside the uterus. Do we need to look inside the uterus in case of a cervical polyp? No. All we need is a speculum and a forceps to grab this polyp and twist it out, right? In contrast, if the option was an endometrial polyp, then that is one place where hysteroscope can help us. So remember, hysteroscopy can only be used, should be used when the pathology is predominantly inside the uterus, right? In Asherman syndrome, what we do is we go inside hysteroscopically, we do an adhesiolysis, put something inside like a Foley's catheter so that the adhesions do not reform, and we try to build the lining by giving cyclical estrogen and progesterone. So the answer in this case will be Asherman syndrome. Remember, if there was an endometrial polyp, then that would also be done hysteroscopically, right? Or if there was a misplaced property, that could be done hysteroscopically. Moving on to the next question. A woman is to undergo complete laparoscopic hysterectomy. She wants to know if there are any advantages through this procedure, if any. What are the disadvantages of laparoscopic over open surgery? Okay, easy enough question. Prolonged recovery time, increased bleeding, not knowing the extent of thermal burns, and increased pain. We know laparoscopy gives a better recovery, shorter operating time, lesser blood loss as compared to open surgery. The only problem with laparoscopy is A, the option C, not knowing the extent of thermal burns, and it has a longer learning curve for the surgeon as compared to open surgery. This was an easy question, we'll not spend much time on it. Moving on to the next question. A 17-year-old girl is seen for primary amenorrhea. She has not developed breast or hair in the pubic or axillary region. Her height is 155 centimeter and weight is 48 kgs, and she has bilateral inguinal masses. On ultrasound examination, there is absent uterus, fallopian tube and ovary. What is the most likely diagnosis? So I have received only 3 recall options here, but for the sake of other questions, we will have some other scenarios as well. So one option is hypergonadotropic hypergonadism, one option is complete androgen insensitivity, and the third is Turner syndrome. Now, it is very good and important if you have studied everything conceptually, but solving questions is a different ball game. Always look for clues that are given to you within the question. So the biggest clue for me in this entire question is this patient is phenotypically a girl, but she has bilateral inguinal masses. Whenever you hear primary amenorrhea with bilateral inguinal masses, always think of undescended testes. Always think of undescended testes. So this patient is phenotypically a girl, but she has bilateral inguinal masses and she has no ovary. We know ovary is made in the absence of Y chromosome, right? So she has bilateral inguinal masses with no ovary, means even though phenotypically it is a girl, the genotype is XY. So the first thing we have gotten out of the way is that the genotype is XY. And the moment we know this, we can immediately exclude all the other genotypes that are present in our question. So for example, if another option was given to you as PCOS, or another option was given to you as MRKH or Mullerian agenesis, we could immediately rule these out. So this is XX, not the answer. MRKH, not the answer. Turner syndrome we know is XO, not the answer. We are left with complete androgen insensitivity, which can be XY, and hypergonadotropic hypogonadism, which can be XX and XY. So we can keep these in our options, right? So the other thing, like, you want to know other ways in which you can rule out MRKH. We know MRKH is Mullerian agenesis and they do not have absent fallopian tube, but ovary should be present in MRKH. This patient does not even have an ovary, right? Because obviously this patient is XY, it is not XX, right? So coming to the two options that are left with us, complete androgen insensitivity, always remember this image of a tall girl. Tall, beautiful, well-developed breasts, no axillary or pubic hair, might even have sisters who have a similar phenotype, right? This is how androgen insensitivity will typically present. This patient does not have secondary sexual characteristics, right? And she is not very tall either. She is not short, so Turners we have already ruled out, but she is not very tall either. So it is not complete androgen insensitivity. Coming to the last option, so by exclusion we have hypergonadotropic hypogonadism. But you may ask, how is this hypergonadotropic hypogonadism? Whenever you have hypergonadotropic hypogonadism, it means that this patient will have hypogonadism, but your LH or FSH levels will be increased. LH, FSH we know are being downregulated by the final hormones that are being secreted, that is estrogen, testosterone. So if estrogen and testosterone are low, there is no negative feedback going to our pituitary, and therefore LH and FSH will rise, which means there is an end organ dysfunction. The end organ, be it our ovaries or our testes, are not secreting the terminal hormone like estrogen, testosterone or DHT, as a result of which there is no negative feedback and LH and FSH are rising. Now this can happen due to two things. Either our end organ dysfunction is there, that is the end organ is dysplastic, as in gonadal dysgenesis, commonly called Swyer syndrome in males. And the other thing it can be is that your testes are fine, but the receptors for your LH and FSH are not working. So the second thing that we have is LH receptor defect. So we typically have only LH receptor defect, we do not have FSH receptor defect. So you might get a question in which they give you the hormone levels along with it. Even within hypergonadotropic hypogonadism, if they want you to further subclassify whether it is Swyer's versus LH receptor defects, they will typically give you the hormone levels of FSH and LH with it. FSH and LH will both be increased in Swyer's because the testes as a whole is dysgenetic and both of them will be increased. But in your LH receptor defect, your FSH levels will be normal, but your LH will be increased. So if you have a variation of this question, you can solve that also, right? So moving on. a 16-year-old girl is seen for primary amenorrhea. She says she gets cyclical pelvic pain every month. On examination, a central bulge can be seen in the pelvic area. On PR examination, a swelling is seen in the anterior aspect. What is the most likely diagnosis? The options are imperforate hymen, vaginal atresia, cervical agenesis, and transverse septum above the vagina. Right? So whenever we have primary amenorrhea, always try to think whether it is an obstructive type or whether it is related to something else, right? So the most common reason we have is imperforate hymen, okay? But in the scenario that is given to us, let us try to work our way towards it. So you have primary amenorrhea. Typically, if it is presenting with cyclical abdominal pain, it means there is some obstruction. Because of this obstruction, the menstrual blood has no outflow tract, the uterus is getting distended, or there is backflow into the fallopian tubes, forming hematosalpinx, forming endometriosis, and initially there is cyclical pelvical pain which might eventually progress to pelvic pain throughout the month, because if there is formation of hematosalpinx and endometriosis, that can manifest throughout the month, not just during your menstrual cycle, right? So all of these are obstructive causes. All of these will cause hematometra. So because all of these are causing hematometra, all of them can be the answer. What is the one evidence they have given us in the question that will help us differentiate? On examination, a central bulge can be seen in the pelvic area. So in imperforate hymen, because the hymen is a thin membrane, whenever there is hematometra and hematocolpos, this bulge, this bluish bulge will be seen at the introitus. And what is the treatment for imperforate hymen? We will go for a cruciate incision and we will drain it. Right? The other options, if we look at the other options, vaginal atresia. So the other thing that is given to you in the question, on PR examination, a swelling is seen in the anterior aspect. It is something that does not really help us. Why? Because in all of these options, you will have a swelling that you feel anteriorly, because a hematometra will be formed in all of them. What will help us is how much above the anal verge the swelling is felt. Right, because the moment you enter the rectum, if you feel the swelling, that means there is not just a hematometra, there is also a hematocolpos, right? So it could be an imperforate hymen or a low transverse vaginal septum. However, if it is well above the anal verge, you are able to feel the bulge. It means it is only a hematometra or a high transverse vaginal septum, which could mean that it is a high transverse vaginal septum or a cervical agenesis. This can also be presented to you in a question as in an MRI, where they are telling you whether there is just hematometra or hematometra with hematocolpos. So keep this in mind. All right. So let's just summarize this. So this is the uterus. This is the vagina, right? So depending, and this is the rectum. So in imperforate hymen, this is the level of obstruction. Transverse vaginal septum, the level of obstruction can be low, middle, high. In transverse vaginal septum, this is imperforate hymen. Transverse vaginal septum can be present throughout this entire place. If there is cervical agenesis, this will be the level of obstruction. And if there is vaginal atresia, again vaginal atresia depending on what is the pathology, maybe it is Mullerian agenesis, as a result of which the upper 2/3 of the vagina will not be formed, or so depending on that, vaginal atresia also, like transverse vaginal septum, can present at any level. So I know if this is my level of obstruction, I will find only hematometra. So my swelling will be felt well above the anal verge. However, if it is imperforate hymen, the moment I enter, I will be able to feel the hematometra as well as the ballooned up cervix, which is the hematocolpos. This can also be given to you in the form of an MRI that this patient presents with hematometra. So if there is just hematometra, no hematocolpos, then we know the obstruction is at an upper level. If we have hematometra with hematocolpos, we know the obstruction is at a lower level. Alright, moving on to the next question. A 28-year-old woman with multiple sexual partners comes with a history of lower abdominal pain for 1 month. She says there is minimal discharge present and complains of intermenstrual bleeding. What is the most likely cause? The options given are Neisseria, Candida, genital TB and herpes. Alright, so this is an interesting question. So what is given to us is we have a woman in the reproductive age group. She has a risk factor which is multiple sexual partners, and she's coming with complaint of lower abdominal pain. So lower abdominal pain, bells should start ringing in my head. Maybe they are describing a case of pelvic inflammatory disease, right? She says there is minimal discharge at present and complains of intermenstrual bleeding. What is the most likely cause? So straight away when I look at these options, we know what is the thing that is causing PID. So herpes we know will cause painful lesions but not a PID. Genital TB we know can cause a PID, but mostly the age group will be younger women or women who are not sexually active, right? And this is not transmitted sexually. Candida we know will mostly cause vaginitis and not cervicitis or PID. Neisseria we know is an organism causing PID. So the answer over here is Neisseria. Remember, whenever you are being given a question of STI, always try to classify it, whether it is predominantly a vaginal discharge type problem, whether it is a cervicitis type problem, or whether it is mostly a PID type problem, right? So if it is typically vaginal discharge, then we know it is our fast 2 kit or our second kit, which is the green kit. How I remember the green kit is, we know a common cause of vaginal discharge is trichomonas, which causes a typically green discharge, and that is how I remember this is the green kit. So trichomonas and candida are predominantly the organisms that are causing this vaginal discharge. So correspondingly, we have secnidazole and fluconazole. If they are giving you a picture where there are cervical erosions or there is minimal discharge and there is cervical motion tenderness and typically a picture of cervicitis, then we know the organisms most commonly causing it are chlamydia and Neisseria. And correspondingly, this is kit 1, grey kit. Correspondingly, the treatment is cefixime and azithromycin. Thirdly, if you have a picture where you have cervical motion tenderness along with some discharge, plus there is lower abdominal pain associated with fever, you're doing a pervaginal examination, you can feel adnexal masses, it's boggy, you might feel there is a TO mass, for example, then think more towards in terms of a PID. And PID is kit 6, which has a 14-day course of doxycycline and metronidazole, along with a single dose of cefixime. Always remember to give partner treatment whenever you are treating for STIs, right? Moving on to the next question. A woman comes with complaints of difficulty in walking, sitting, pain and swelling in her perineal area. She has a history of multiple sexual partners. On examination, a tender swelling is seen with redness on the labia. What is the likely diagnosis? So again, the answer has been given away in the question. So this is a Bartholin cyst. How do we know it as a Bartholin cyst? We know the Bartholin gland is present at the junction of the anterior 2/3 and posterior 1/3 between the labia majora and minora, as we can see over here. And the opening of this gland is right beside the introitus, right? So this is typically the area where we are seeing the swelling. So whenever you see a swelling in this area, remember it is either a Bartholin cyst or a Bartholin's abscess, right? So the other question they can ask you in Bartholin cyst and Bartholin's abscess is, what is the treatment of this? So the treatment for Bartholin cyst and Bartholin's abscess, whenever you have an abscess, no matter in which part of the body, friends, remember the answer will be incision and drainage. Never mark marsupialization. Okay, whenever there is an abscess, first the infection has to be treated with a course of antibiotics, incision and drainage has to be done. Only then, when the infection has settled down, can we go for a treatment. If you have a single time, first time occurrence of Bartholin cyst, again you can go for an incision and drainage. But if the Bartholin cyst is recurrent, then we go for marsupialization. Marsupialization comes from the word marsupials, which are basically the terrestrial animals in Australia like kangaroo, which have a pouch. So basically what we are doing is we make a nick, we drain what is inside, and then we kind of sew the bag into the rest of the tissues so that the bag doesn't join and reform, the fluid does not form again, right? Another trick question that may ask you, if I were to just modify this question a little and say a 45-year-old woman comes with the same complaints, right, and history of multiple sexual partners, and this is seen, what will be my first line of management in this? So remember, occurrence of a Bartholin cyst in a woman above 40 years of age should ring alarm bells. Is it a cancerous growth? So we will go for a biopsy from the mass and the treatment will be undertaken according to the biopsy results. Okay, that's it about Bartholin cyst. Coming on to the next question. A 50-year-old woman presents with foul smelling bloody discharge per vagina mixed with mucus. On examination, a necrotizing growth can be seen in the cervix with lateral parametrial involvement. What is the management for this patient? So, right at the offset, we have a very clear picture of cancer cervix. We have a woman in the correct age group for the cancer. We have the typical complaints that they come with. It is a foul smelling bloody discharge mixed with mucus. And on examination also, you can see a necrotizing growth. What else can you see? Lateral parametrial involvement. So whenever this kind of a question is given to you, you have to do it in stages. 1, you make the diagnosis, CA cervix. 2, they're asking you the management. Management is dependent on stage. So from the examination that they have given you, you have to tell what stage it is, right? So I can see there is a growth. They have not mentioned the size, but what they have told me is the lateral parametrium is involved, which makes it a stage 2B. Right? So this is a stage 2B. So finally, if I am to condense this question, what they are actually asking me is, what is the management of cancer cervix stage 2B? So you have to break down the question like this, right? So we know cancer cervix is actually one of the only cancers, most gynecological cancers that you will see is we have neoadjuvant chemotherapy followed by surgery, or we have surgery with adjuvant chemotherapy. Cancer cervix is a form of cancer where we have either surgery or we have chemoradiation. We rarely, if ever, go for both. We don't want to go for both. Reason being, the morbidity of the surgery and the chemoradiation put together is so much, it gives so much morbidity to the patient that the patient actually feels, I would rather die of cancer itself than the morbidity this treatment has given me. Right, there is formation of fistula, there is incontinence, there is diarrhea, there are myriad symptoms, and the patients are very troubled by it. So we go for either surgery or we go for chemoradiation. So we know that the options we have with us are chemoradiation and surgery. Chemotherapy on its own not given in cancer cervix. We will come to option B, brachytherapy, a little later. So when do we go for surgery and when do we go for chemoradiation? So remember, whenever we have a small cancer, wherever we feel that we can resect almost the entirety or the entirety of the cancer, we will go for surgery. So whenever there is a small CA cervix, which means stage 1, stage 2A1. So up till stage 2A1, we can go for surgery. There is, however, one exception in this. What is the exception? The exception is stage 1B3. And what is 1B3? A cervical cancer growth which is more than 4 centimeters. So as an as a different question, they might just give you the measurements. So anytime they give you, and the greatest dimension, they give you a size, say 3 into 4 into 3 centimeter. If the greatest dimension is more than equal to 4 centimeter, you will not go for surgery. You will go straight away for chemoradiation, right? So that is it for the treatment of cancer cervix. So brachytherapy is actually just a modality, but the broad term, if we talk about, we will go for chemoradiation. And why chemoradiation? Because giving chemotherapy before radiation sensitizes the body and the cancer to absorb more radiation and kills the cancer faster. So that's it for the PYQs. Thank you.